So our first speaker is Annie Richter. Have I said that right?
Very good, yeah.
Oh, not bad. Okay, over to you.
Hello, everybody, and sounds like you can all hear me. My name is Annie, and I'm here today not because of my professional background or because of my involvement in patient-oriented research. I'm here today to share a story with you, to put a human face on overdiagnosing and subsequently overtreatment. And thank you for inviting me. I really appreciate that. I like to share the story of my father-in-law with you today. Charles was 92 years old, as he still lived very independently, fiercely hang on to him still driving, what we were not in favor of, but you couldn't take it away from him, and lived alone, fairly sound health physically, but especially mentally strong. So for him, everything what was meaningful was freedom, independence, not having to rely on others. He had a massage treatment, and the therapist made an incidental finding of a growth in the back of his neck. Already there, put out the word, oh, you have to have that checked out because it could be cancer. So you gotta really go. So he made an appointment with the family physician, and the doctor said, yeah, let's check it out. So ordered a scan and a biopsy. That's when I heard about it. So I was trying to talk to the family and bring them all together, and I said, it's like, honestly, do we really want to know it? Does Charles want to know? And the consequences it could have. But the biggest opposition I get from the people who wanted, his children, who wanted everything be done, and these were the ones who were then not there to help with his care, but really pushed for it. Because I caution that if we have a diagnosis, we still have to consider treatment. But certain diagnoses, especially with the cancer diagnosis, there is a big fear factor attached to it. I'm a cancer survivor myself. I know what I'm talking about. And so even if you decide then not to treat, it's still this devil sits in the back of your neck, and with this diagnosis, and it changes things. Sure enough, the result ended in a cancer diagnosis for Charles, and treatment was recommended. 30 radiation treatments, and maybe surgery. But Charles was assured that this is a cancer we can not just treat, we can cure it. So all he heard is the threat of cancer and cure. The side effects mentioned was pretty much just, he make it tired, and not really getting into any discussion about harms or benefits. So again, I tried to offer a different point of view and questioned if that's really the right path. But family dynamics are interesting if it comes to sharing the workload. You are a family member. If it comes to decision making, you're not one of the kids. Right? And so it was quite interesting. So I just caution that overtreatment is not the only possible harm arising from this overdiagnosis, especially so late in life. But for example, just like I mentioned before, the knowledge of the abnormality, the presence there is very stressful, even if you decide not to go for treatments. So as we started the radiation treatments, that meant a good 3-hour round trip every day to the cancer center. These, just to drive, the getting ready, the time, being on time for a very short treatment, but all what it took, and the treatment itself took its toll on my father-in-law fairly quickly. He became very tired, he lost his appetite, and got weak. Especially the change in the interest. He wasn't interested in really anything anymore. And he was a very opinionated, strong-headed guy, like discussing politics. So the change in his personality was tremendous. The oncologist then suggested that they should stop after the 15 treatments. But by then, even Charles himself, besides the pressure from the children, they were invested in, oh, no, we don't want a shortcut because we may jeopardize the cure or the possibility of a cure. Towards the end of his treatments, he became so weak that he needed help with even getting dressed. And as I mentioned before, he was fiercely independent. That was really, really difficult for him to ask for help and actually take the help. His health, his liberty, the opportunities for social interactions, and the ability to maintain interests and friendships, all was taken from him. Then he got shingles. He was admitted to the hospital, to the isolation ward, and that's where he died. Alone, in a strange environment, everybody fully dressed, protected. It was so sad, just seeing this strong person within a short period of time to see the effect what that had. And I'm convinced if we just would have left alone, not diagnosing and especially not treating, and I see that quite often, so late in life or the end of life or with very ill people, that more resources get put towards that and we try to extend life. And I'm often asking myself, is like, what are we aiming for? The everlasting life? I don't know. So Charles was not given the autonomy to make informed decisions, including the option to refuse diagnosis or treatment. Risks and harms were not explained to him. There wasn't a care conference with everyone involved and really outweighing the risks and harms. What is acceptable for this person, for the individual? And looking at the different forms of harms against the perceived benefit. Alternatives were not offered, like watchful waiting, palliative care. These all would need time. If we do that, and we need time, but we also need the courage to address that. And our system with fee for service and 5 to a long visit is 10 minutes with the family physician, that just wouldn't allow that. So Charles and his children actually made a decision on a very limited and possibly even inaccurate informations. The data they would need it to make a fully informed decision or give informed consent was simply not available or provided to them. There's still this impression out there, oh, if the patient says yes, that means that's consent. And that's far from being an informed consent. But I see also besides the implication on the healthcare system, this over-treating, over-diagnosing, over-treating has, especially so late in life, we as a society also must learn to accept death as something natural. And become comfortable to talk about that, to address the issue. Many healthcare professionals still have a hard time to address the issue of death, and it is perceived still a bit as a failure. So I better not go there. But the focus has to shift onto life quality and not quantity. And we have to all become comfortable to approach the subject with the patients and the family. Advanced care planning should be mandatory, not at the time where we are in a crisis already, earlier on. We have to improve palliative care and end-of-life decisions given to the patients and the families. We have to become comfortable to speak openly about the implications of a diagnosis and a treatment for the individual, and like I mentioned before, especially so late in life. It needs courage, and we have to teach that to our medical students from the beginning. We have to implement that throughout the education and leading by example. Allowing this to happen naturally without interfering is not a failure. It's the opposite. It's quite often the last gift you can give to your loved ones and to your patients. Thank you all for letting me speak here today and sharing this story. And I hope when you're in a tough decision that hopefully you remember that. And then I thought, oh, I got to stop and pause and really make sure which way I want to go there. That more is not always better, and quite often not diagnosing and not treating might be the better choice. At least a choice you have to give to your patients. Like I said, it might be the last gift to give that really counts. Thank you all for listening.
Annie, thank you very much. That was a very sad and difficult story that I think you told beautifully and with great wisdom. Thank you. I think we all know that despite everything, we haven't managed to help people live longer, and we haven't managed to achieve what we call compression of morbidity. So the points you raise are very pertinent. Just two things to say. If you're online, do send in your questions. We do want to have questions at the end. And I forgot to declare my competing interests. The BMJ is an active supporter of this whole movement, and you have our commitment to that. And what we want to see is the evidence, the science, the goodwill, the energy turned into change, to create action, to achieve change. So we're committed to working with you to do that. Our next speaker is Jessica Orte.
Hi, can you all hear me at the back? Great, thank you. So Annie, it's such a compelling story, and I'm hopeful that I can tell some different stories, how it could go differently. I'm Jessica Orte. I'm a family doctor on Vancouver Island. I wear a lot of hats, but I do work in palliative care primarily and in long-term care. And I work with the Therapeutics Initiative, which is an organization in British Columbia, and our goal is to help ensure that drug therapies are used wisely in the best interest of patients, and that's based on an accurate understanding of scientific evidence without conflict of interest. So on that note, I don't have any particular conflicts to declare. I work on a lot of committees. I wear too many hats. I think all of these things are complementary here, but I don't have any commercial conflicts to declare. As Annie began, she talked about why we're all here. She told a story that is exactly why this conference exists, and we were hoping that to help close the conference, we would focus on solutions. So the problem is that overdiagnosis is a really hard thing to measure, even looking back in time. you can do it at the population level, but there's no way to know for the individual. Are you the person who benefited from taking that statin? Or, if we found your prostate cancer sooner with a PSA, were you a person who benefited from that? Should that be the case? You can't actually tell if you're the one who was overtreated, overtested, or overdiagnosed. But even if we can't tell if it's happening at the time, there are active things that we can do to prevent it, to try to give our patients care that involves less overtesting, overtreating, and overdiagnosis. So this is measurement. Why do we measure? Measurement alone doesn't really do anything, but it can be used to create accountability when you pair it with a system change, maybe a regulatory decision, a funding decision, and hopefully it will shift performance of a system to make it better. And we're always looking for this high-performing system, and when I was preparing for this, I researched that, and I found there's no consensus on that. The RAND Corporation in the United States looked at what is a high-performing health system, and there's a ton of different ideas, but no consensus, and we've looked at all the little pieces of systems, access to care, good diabetic control, and we can articulate those clearly, but there's no one universal definition of good health care or high-performing systems. And I was reflecting with others recently in our discussions about the COVID pandemic. At the beginning of the pandemic, we were really concerned about access to ventilators, overall case counts, and mortality. And then as the pandemic went on, at least in Canada, we started realizing there were other things that mattered. The arts were failing. Innovation wasn't thriving. The economy was ruined. There was mental health implications, both from COVID and from the actions we took to try to counteract COVID. And there was environmental waste. There were so many things going on, and our governments and leaders had to decide which to prioritize. And it was hard to do. So the question is, how can we develop health policies and systems that reflect our social values? And that's something we need to get at with measurement. This is a bunch of grapes. How many grapes do you think are in this bunch? I'd love you just to shout it out, or online you can type it in the chat. How many grapes? 35. 35? 50, 60, 200. Whoa, okay. You don't get a prize for guessing correctly because I actually don't know the answer. Guess how many grapes are here? It's the same number of grapes. Do you want these ones? Measuring the number of grapes doesn't really get at what we're trying to do, but that's kind of what we do in healthcare. We measure the grapes. I would rather know about their deliciousness, and I don't think I'd like to even taste these to find out. So I have 3 ideas, things that we can do tomorrow at the patient and doctor, patient, nurse practitioner, patient provider interface to try to improve the care that we give. And the first is around goals of care and prioritizing those, which ties really into what Annie has been telling us about. Right now, we're measuring a lot of those wrong things, like the number of grapes. And instead, those are things that don't really matter. Instead, I think we should ask patients, what matters to you? And I've got the button on for the campaign that's internationally not that well known. It says, what matters to you? And I ask almost all my patients that, because when I know that, I can figure out how it can help them make decisions. So I want you to pause and think, what matters most to you? Here away at this conference, I'm thinking of my little kids at home. I'm thinking I would like to spend as much time with them as I can. I play hockey, ice hockey. I want to play hockey. I want to be able to garden until I'm old and gray. What kinds of things do you want to do? Just thinking about that. Did any of you say that you'd like to lessen your chance of heart attack or stroke by 1% over the next 10 years? Or you want your blood pressure to be, your systolic blood pressure to be under 130? That's not how we think about it when we're coming at life. But unfortunately, that's how a lot of medical decisions are made, and we forget to ask people about how to support them in their particular goal. This is a CT scanner. Health systems usually measure their success perhaps in throughput. We did more CT scans this year. Great, looks good on a report, but more is not always better, as we all know. What about C-sections? In Canada, the rate increased back in 1997, 8.7% of deliveries were by C-section, and in 2016 it was 28%. Is that medicalization desirable? It's probably better to look at outcomes, right, and not throughput. But we struggle with that. Most of the measures that we use are proxy measures, like hemoglobin A1Cs. They're not really a good correlate with outcomes of diabetes. We think a lower A1C is probably a good thing, fewer bad things will happen to this person, because originally that's what our thinking was. And we wrote guidelines that said more drugs, lower the A1C. But unfortunately, turned out A1Cs don't necessarily correlate with the things that patients worry about that matter to them, and also that being too aggressive with these things can cause some serious harms. Clinical research, like clinical trials, often rely on these unimportant measures, right? And they fail to take into account things that matter to patients, like their ability to function or to avoid a life-altering event. Basically, different things matter to patients than to drug companies. I want to tell a short story. I know we're running over time, but I think it's really important to tell a different story than what Charles experienced. And I stole the idea of a program in the emergency room to prevent avoidable admissions of frail elders from another institution I'd worked at, and I brought it to Nanaimo. And I was working there, and I met Charles. I'll use a different name, William. I met William, and he was hooked up to a nitro drip. He'd come in because he was dizzy. He was just not feeling right. So he came in by ambulance. His blood pressure systolic was 220, and he just wasn't feeling good. So they put nitroglycerin, and I was asked to see him because he wanted to go home. And the emerge doc said, "There's no way you'll get this guy home." So I went and I talked with him, and I said, "What's going on? How are you feeling?" "Oh, I feel dizzy all the time. I just want to go home. I just want to play cards with my family." And we talked more and more, and I learned he'd been dizzy forever. He was just having a kind of a bad day. He didn't always take all his medications. He had a bunch of chronic diseases, and he thought that many of his medications were making the dizziness worse. So together, William and I decided to stop most of his medications. And we knew that he would be at greater risk of having a heart attack or stroke, but he just wanted to go home. And he didn't want to be on these medications, knowing those risks. So I sent him home. And a few months later, I was working in the emergency room again, and there he was. William was there. He had a heart attack. And I went over to talk to him. I said, "Oh, how did it go?" I heard, because we have community pharmacists who were following the deprescribing and helping him get off even more things. And I knew he was out there, but when he came back, I said, "How did it go?" He said, "I got to play cards with my family. I could sit up. I couldn't walk down the driveway like I had hoped. He couldn't walk before. But I got to play cards with my family. You saved my life." And I thought, okay, your heart muscle is dying. I'm watching you in front of me in the monitor. This is bad. But he said, "You saved my life." And you know what we did? We gave him some pain medications. We sent him back home. He had some home care there. He came back into the emergency room another time. This time his wife was feeling a bit overwhelmed caring for him because he'd lost even more function. And he didn't want to be a burden and die at home. So he wanted to be in our palliative care unit. And I work in palliative care, and the universe lined up, and I happened to be the attending physician. He came to palliative care, played cards with his family, and he died. And I'm tearing up. This is crazy. It's just so meaningful. I don't save lives in the way that you think of. But it really meant so much to that family to have that experience. And by all metrics, I had failed, right? His blood pressure was ridiculous. He had a bunch of heart attacks. He probably had more heart attacks than we even knew. He'd bounced back to the emergency room a couple of times, but I saved his life. So I think it can go a different way. Number 2, why I'm emotional, the doctor and patient relationship. A lot of our health systems favor fragmented care, transactional care, and through virtual care, I think that's gotten worse. But my idea is that we need to put more eggs in this basket of longitudinal relationships, because we know that more than any test or drug, that caring for people matters. And in a person's life, whether it's someone who loves them or feeling part of community, that matters. But also in terms of primary care, there's tons of evidence, including some great reviews from Alberta, that show that continuity reduces some of those hard measures like emergency visits, morbidity, mortality. And even though those aren't perfect measures, there's something to this. So if we can design systems that incentivize longitudinal care, we can make progress in some of those hard outcomes. And also in progress in the things that matter more, like the patient's experience of care and the caregiver's experience of care. This is a transactional relationship. We know that doesn't deliver the same benefits of a continuous relationship. There's some kind of secret sauce in a caring relationship that permits an approach that doesn't when a patient's asking and they're worried about something, you don't have to answer every question with a pill, every worry with a test. We know that primary care physicians who spend time educating their patients about their health, who laugh and joke with them, who talk to them about what matters to them, they're less likely to get sued. So those who are worried about malpractice and when they say no need not fear that. A solid relationship creates a safe place for shared decision-making and also comfort with uncertainty. Yeah, who went to the tower last night and tried looking down? This is an actual emergency room note, not from me because, look, there's urine. I wouldn't have ordered the urine. But this was a colleague's note, and I thought it was beautiful. Healthy adult plan, reassurance, follow up with his family doctor. I thought that was really cool because that was a sign we had been shifting the culture in our emergency department through our program, I think. I'd like to believe that our team could take some credit for that because I hadn't seen something like that before. The other thing that a continuous relationship allows is for reassurance and the tincture of time to be applied twice a day, affected areas. I have another story about one of my long-term care patients. So a nurse called me and she said, "Oh, you've got to come in. Clara's feet are really bothering her. Her legs are really sore. Can you come see her?" Of course. So I went in to see her and assessed her dusky feet. And she also told me about the people sneaking into her room at night, taking her things, her belly pain, her poor vision. She apologized. She said, I always give you such a list of things and bother you with this, and I feel so bad about that. And we talked about each list item, as we always do, and I gave her a preliminary diagnosis after I examined her. Okay, this is what I think is going on here and there. And we talked about the plan that we might undertake, and I'll go touch on that more in a second. She said, "Just you coming here, knowing that you believe me, that helps me. I feel better just talking with you." And she says that every time, because that's the kind of person that she is. But in medicine, we often forget two important things. The first is that evidence-based medicine, it's not about reading the latest trial and then applying that to the patient in front of you. You should do this because in this study, that was a good thing, right? Instead, it's this fine dance of integrating what the evidence, best available evidence shows us with the patient's goals and our clinical expertise to guide them and help that patient achieve what they're trying to achieve. The second thing we forget is that it's not okay to say, Clara, you should do this. It is okay to make recommendations based on this structure, considering the best evidence and the patient's goals. So for Clara, I said to her something like, well, I could send you to the hospital for a CT of your legs, and it's probably going to show that the arteries are blocked, and that's why there's no blood flow to your feet and why they're turning purple and why they hurt. Then you would be sent to Victoria to see a vascular surgeon who could probably do some re-plumbing and fix things up. But I worry, I think the surgery might go okay, but I worry with your heart and your lung conditions that you probably wouldn't bounce back from that. And also, you have beginnings of dementia and memory troubles, and that experience can be quite stressful, and I worry that, you might not be quite as sharp from that. You might also find it, I know that she finds it distressing even to leave her room in the facility, and I said, that's distressing, and I worry if you go down this pathway, you're going to be stuck in the hospital. You won't be able to spend time with your family or watch nature shows on TV, and you won't have that cognitive strength that you have now. So what I would recommend is that we treat you here in your room, and we use whatever we need to do to keep from being ulcers that are problematic and try to treat those as they come, because they will come, and we'll use pain medication to help keep you comfortable, and we'll just take it bit by bit together. Does that make sense to you? And she said, yes, I feel better just talking with you, because that's what she always says. But if another doctor had been meeting her for the first time, they probably would have ordered that CT angio. They might have sent her to the ophthalmologist for her eyes, because she has terrible disease. She has everything, all the acronyms. She's got them. But I know that she doesn't want to go. There was a time when she wanted to go to the hospital and have tests and treatments, and now we're past that time. She wants to be involved in the decisions. She wants to be taken seriously and informed of the information and involved in the choice. I know what she's going to choose, but I still invite her to participate, and then we color outside the lines together. So the last idea is that we should allow more warranted variation and less unwarranted variation in the systems that we design, and I think patients and physicians can both be involved in advocating for this. You know Jack Wennerberg, who founded the Dartmouth Atlas of Health, and we heard from Otis Brawley earlier about disparities in health. The idea is that some people are treated differently based on where they live or their socioeconomic status or things that don't have to do with their medical context or with their own goals. And this has everything to do with inequity and nothing to do with medical evidence, right? That's unwarranted variation. So while we need to ensure that patients have access to the things that they need and that they avoid harmful and unnecessary tests and treatments, we also have to help people we should be able to individualize our care plans to the person in front of us so that we can vary from those. You were talking about the Hep C, this tick box. They don't need it. We should be able to make those decisions with our patients and create systems that make it not a hassle, but the norm. We have to be careful with our metrics. Many of you worked in the UK under the Quality and Outcomes Framework, where there were like 120 measures. They were all tied to financial incentives for physicians. And while some of those metrics, well, first of all, there was excellent adherence to the program, and even better than predicted. And while some of the metrics improved, a lot of other things that weren't being measured got worse because there wasn't time to deal with other things that mattered. So we have to be really careful about what we're measuring and what we're driving with our design of systems. I think I'll just skip on here. This is about closing the tap, and a lot of you are aware of programs like Choosing Wisely and other similar ones, disinvestment or delisting programs where something is removed, it just can't be done. And I think that's a powerful way of allowing physicians to practice the medicine that they need to sometimes, but we also know there are patients who sometimes need to access these things, and those barriers can be quite difficult. I think Fiona is going to talk later a little bit about health technology assessment, so how we can avoid putting things out there and then having to take them back, which is a big part of dealing with variation. And just lastly, there's obviously an art to this, and I know I've got 2 minutes, but I'm going to tell one more story. When my son Elliot was born, that's the baby I'm always running out to press milk for. So he's at home. When he was born, they said he had a subgaleal hematoma, which is something I'd never heard of, but a big blood lump that could turn into an even bigger one, and he could exsanguinate and die. And so the pediatrician, who I'd never met, came in and said, we need to put an IV in, we need to bring him to the NICU and monitor him. And I just looked like I must have been blank. The nurse who was in the room said, oh, doctor, is that really necessary? And the pediatrician said, let me think about it. She left the room, she consulted the institutional protocol, she came back and she said, you know what, baby can stay in the room, we'll just watch, we'll see what happens. And everything was fine, we were all happy, everything turned out beautifully, and yet she failed to apply the institutional protocol. She would fail on some measure if there was a measure for this. But it was the right choice for all of us. All of us felt good about it. How can I put that on a scorecard or a graph? I can't. We can't measure very easily and reproduce the culture that allows that kind of discussion, that allows us to make mistakes or change our minds. But there has to be room for that. I'll skip to the end because we have some really compelling presentations next that are going to give us bigger ideas that we can apply. But I just wanted to summarize the things that we need to do. So instead of getting excited about surrogate markers, let's ask patients what matters to you and let's act on that. Don't feel afraid to make recommendations if they fit with the patient's goals and values, and do that in a continuous and trusting relationship. And lastly, we should all insist on a system that allows warranted variation and gets rid of unwarranted variation. Thank you.
Jessica, thank you very much. A really interesting argument, I think. I mean, you're arguing for some variation based on patient preferences, but really arising from a very strong doctor or clinician patient relationship. So food for thought. Okay, next we have Todd.
So thanks for having me here. I'm Todd Anderson. I'm a cardiologist by training. I look after patients a day a week and have been doing so for decades, given my advanced age. And the previous two presentations resonate with me very much. This is what I strive to do on a day in and day out basis with my complicated, challenging, frail patients who we keep alive after their heart attack, but who run into trouble. The hat I'm wearing today that I'm going to talk to you about is over the last 15 years or so, I've spent a lot of time as a medical administrator. and first as a department head in cardiac sciences and now as a senior leader within the Cummings School of Medicine. So I wanted just to give you some thoughts around this. What I've looked at is someone who's had to control budgets going forward, and somebody who has had to make difficult decisions in terms of where resources are allocated, and then somebody who's tried to make some changes in the choosing wisely sphere. Most of what I bring to this conversation today is on the over-testing side, but it really has made me think about the over-diagnosis and the over-treatment slide. So I pulled this slide up. This is, known to all of you. There is a sweet spot in green there where we do population screening, really with the hope of creating a true negative test for that patient. Mrs. Jones, you have a great blood pressure, your cholesterol is good, your risk of having a heart attack is low, and we will follow guidelines. So no action required. Or the true positive, you do a test based on your clinical acumen that then helps you make some diagnosis. You have chest pain, I've ordered this certain test, the test is positive, we can go forward. But there's all this other stuff on the slide that this conference was about, where if you haven't chosen well with that testing, i.e. you've over-tested, that will lead to diagnoses that either are not important or are in fact false positives. And then once you have something in front of you as a clinician, it is very difficult to ignore those things. So over-diagnosis then can certainly lead to over-treatment with all of the consequences that you've heard about. In Alberta, this is what primary care clinicians look at with respect to the maneuvers that have been recommended by the government for what should be screened. So this is the recommendation. Every jurisdiction has this, every country has it, and you can see on there there's the usual kind of players. Whether this is right or not, it's unclear, but this is a guideline to start with. The first problem is do we have this right? Are all of these things, if we do it patient-centered, do we make the right decisions for patients, or do people follow this? You will notice on here that most of this is cardiovascular, that's why I'm comfortable showing it, and many of it is cancer. And for cancer, you can argue, when should mammography done? You will not see a PSA on there, yet a number of our colleagues, our urologists, would argue very strongly for that. And so people will be outside of the usual realm in terms of screening. So for asymptomatic population screening, we don't always get it right. We have guidelines to follow, but sometimes that doesn't lead us to where we want to be. So if I think about this for low-value testing, there's lots of things that are there. Many patient, practitioner, and systematic reasons for this, and I'm just going to talk to you about a few as a cardiologist that works in this system in Alberta. I'll give you some examples here on straightforward things, and I'll talk to you about some things I found on duplicate testing and the overdiagnosis and overtreatment, all of the things you heard beautifully from our previous speakers. So I'll give you an example of the simple ECG. So people say, well, what's the big deal about somebody doing an ECG? So I'll give you an example from a patient that I saw about a month ago. I followed them for a number of years. They had a heart attack. They've had coronary disease. Their primary care clinician ordered a routine ECG. They were feeling absolutely well. The ECG came back that says, oh, since your last ECG, you've had a heart attack. This individual was supposed to go on a great trip, within a week later, and because of that, they were incredibly angst-ridden. They had the ability to go and get a private test, a CT coronary angiogram, and then they called my office with the results of both. I brought them in to see me. I looked at the ECG. I looked at their old ECG. I looked at their coronary angiogram, and I said, do you want the good news or the bad news? I said, okay, well, give me the good news. I said, well, the good news is you've not had a heart attack. The bad news was they put the leads on incorrectly on your ECG, because I repeated the ECG in the office. I knew it just by looking at it, because that's what I do as a cardiologist. And I said, the technologist put the leads on incorrectly. It thought you had a heart attack. You've just spent $1,000 to have a CT coronary angiogram. You've been super worried for the last week. So that's the downside of the asymptomatic checkbox test for individuals. And unfortunately, we do it with the best of intentions, but asymptomatic people should have minimal testing. So there's an example that I looked at. This is a study that we did. This is duplicate testing, so this is a different thing. This is in somebody, so this was 8,300 patients who have had a heart attack. And it was my impression as a practitioner is that we did way too many tests on these people. So if you've had a heart attack, it is a recommendation that you need some assessment of your heart function so we can decide what medications you should be on and whether you're at risk of sudden cardiac death. So the first thing there is that you can see is that while in the hospital, 49% of those patients had 2 different tests. They had what's called a coronary angiogram, where they'd inject dye into the heart at the time of their catheterization, which most people have, and they also had an echocardiogram. So they had 2 different tests to assess the same thing while in hospital, 50%. Each of those tests cost $250. Some of those tests have risks. So that was the first thing that was a bit disturbing for me, is why were we doing 2 tests on the same patient? And then when we looked in follow-up, is that in addition to that, as you'll see there on the bottom in blue, more than one follow-up assessment, 55% of people had another test done, okay? Now, if you have poor heart function, so-called group 3 patients there with decreased heart function, that would be appropriate. For the rest of those individuals, the majority got 3 tests of their heart function the first 6 months instead of 1. And what that means is extra time, going to the clinic, having the tests done, and extra expense for the healthcare system. So that's why I was looking at it, because as somebody who has to control budgets, that was a concern for me. And none of these things fit into the wheel of quality. So you've chatted about this, you live and breathe this, but quality in Alberta Health Services or whatever jurisdiction you live in really is about the things that you want to get to in the middle, patient-centered care, and we have these determinants of accessibility and appropriateness and effectiveness and efficiency and safety and acceptability. Doing tests inappropriately on people and the consequences thereof don't fit into any of these things. This is just poor from a quality point of view, and even if you're not one who has to follow the budget, this is poor for patient care. This is poor for wait times for people who should have testing done when they need it, but they can't because inappropriate testing is leading to that. This worries me a lot. In Canada, last year, we spent $308 billion on healthcare. Now, COVID increased that a little bit, but you can see the rate of growth of that in the green line over about the last 20 years or so. We thought that a constant increase would be the other line, but the costs have gone up through the roof. And we're all responsible for this. We're not all to blame, but we all are in some measure. Behooves us to think, in addition to while we want to do patient-centered care, if you look at quality, then cost things will follow, okay? So you shouldn't be doing things because of cost, but cost is a reality for us. And in our province, we spend 43% or 45% of the provincial budget on healthcare, and that number is getting larger and larger as we go forward. Okay, and what we know from the Canadian Institute of Health Information is that about 30% of the things that we do are deemed to be low value. I don't like the word unnecessary, but low value. 30% of lab tests, 30% of imaging, 30% of pharmaceuticals, 30% of hospitalizations or consults, all of those things. So it would give us lots of leeway to do other things to make patient care better, but it would also help us with our cost issues. And most individuals are unaware of this, or those that are aware, what we haven't been able to do is figure out a way to make that change. So what can we do from a solutions point of view? So how does the healthcare system or the university contribute this? The things that we do or the measurements that we have, how does that occur? So depending on your jurisdiction is that sometimes in a quaternary care center is that it's just easy to access testing. So you think about something for your patient, you can get that tomorrow, and so you do it. Pay for performance with improper surrogate key performance indicators sometimes drives bad decision making, okay? Is that we're going to get paid based on how many of these things that we do. This is kind of gray, we will go ahead and do it. It's not that way in all systems. In our system is that we have X number of dollars. The more tests we do, the less opportunity, but depending on where you're at, that may be the case. In a university environment or in a healthcare system, there is a culture for over-testing for routine conditions. Want to be state-of-the-art. We don't want to leave any stone unturned, and it becomes a culture within especially urban areas, but especially in a university area, that we don't want to be seen to be missing anything. We need to do more about audit and feedback mechanisms. Dr. Lang, who helped organize this conference, they've done great things in the emergency room. They have data that they can present to their emergency room physicians to say, last year, of people who came in with a headache, do you know that you ordered a CAT scan 25% of the time? And here was the result. Sometimes just providing evidence to people does that, but we haven't been able to do that in an effective fashion. Sometimes the evaluation of a center is based on the number of tests performed. Often that's a key performance indicator. It's like we're the third largest producer of cardiac MRIs in the planet. That's a great thing. They think that's great. We've done 4,000 studies. Now, that may be a great thing, but that's the wrong metric. The metric should be those individuals that we did these scans on did better, they felt better, it was good for them, not just the simple number of tests, as Jessica had alluded to. Guidelines are sometimes not patient-centric, and sometimes we don't ask patients what they want, and that's an important deficiency. And then, hate to bring in the elephant of the room, but depending on where you live, sometimes tests are ordered because it is financially advantageous for the individual practitioner, the clinic, the healthcare system, or the university. Not to say this is why decisions are driven, but sometimes that is the case. You have a widget in your office, you get paid to do more of those widgets for your patient. All of a sudden, every patient looks like they should have that widget done to them. And before you know it, everybody has an extra test that comes through. Those tests then generate these false positive findings or low-value healthcare. Okay, so I like this quote, the current care systems cannot do the job. Trying harder will not work. Changing systems of care will. This is 20 years old now from the Institute of Medicine. Like to think that we've come some way around this. Clearly, this overdiagnosis conference is one step in that direction, but I would put it back to you that we haven't figured this out completely. Okay, so what does this look like then? How are the solutions at the healthcare system? What are the things that we can do? So I think research is probably the most important. I've resisted the temptation to put any research slides in here because, one, that would be silly because this is not what I research, and a lot of you do. But this is how we have to change care. We have to have patient-centric key performance indicators, and we have to have payment schemes that do not reward over-testing or over-treatment. That shouldn't be the end goal. The end goal should be the patient-centered metrics that we want. We want to increase audit and feedback and quality improvement initiatives. Those are some of the things that we should be doing as a healthcare system and a university. I'm a big proponent of the Choosing Wisely movement, wherever you're from. I think a lot of work has gone into that, and we can make good decisions potentially around that. We have the advantage now of electronic medical records. Alberta is about to get Epic or Connect Care. We can link a lot of data, and we can use those electronic medical records to help us. Clinicians are terrific, but we can use artificial intelligence and big data to help us in those decision-making things. And obviously, we need education and KT events. So let me just show you a couple of things that we've done over the last few years in the cardiology realm. About 5 years ago, I recognized that we give way too many ECGs in our region, and so we institute a series of things where we decreased, you can see here, ECGs as an outpatient with education for our clinicians, some alerts that allowed them to decrease the number of tests that they were doing. In the hospital, as we then said, okay, we're doing daily ECGs in order sets, can we not get rid of some of these? And we were able to, at the Foothills Hospital site, one of our 4 adult care hospitals, decrease ECGs by some 13% over a couple of years. The hospitals where we didn't do anything, that did not change. So what we're able to do then is decrease those ECGs, and we've now implemented a series of things kind of going forward, and we've done that in a organized fashion in Choosing Wisely and Cardiac Sciences to try and move forward with all of these things. I'll just skip that. And then finally, we've involved an advisory patient-oriented research team. This is just in cardiac, but lots of different groups have done it, is bringing the patient voice into this and asking them what's important to them, as we've heard from our 2 previous speakers. And that really has dramatically enriched the things that we wanted to do, and we've used that group for a large number of decisions that we've made moving forward. So we have lots to do at the end of the day, but I think if we can look at a variety of those things, that will be helpful. And then finally, I'm a big believer that paying physicians in a fee-for-service model, where you can see here is that still 70% of our clinicians are paid in a fee-for-service model, that we can make changes in that domain. And that's something that maybe Fiona can tell us at a policy level how we can do these things, because change management is hard. So choosing wisely, embed artificial intelligence, use the patient voice, and think about ways to disincentivize the extra testing that we do. Thank you very much.
Todd, thank you. I think we're all impressed that you're a cardiologist who still looks at ECGs and doesn't rely on some AI machine-learned algorithm. So congratulations. I'm still struggling to shake the image of Jessica's grapes from my brain. But the serious point here is that what we're hearing today is evidence, reasonable argument, and the real question is, why are many clinicians and most policymakers not listening and not acting? Fiona, perhaps you're going to tell us.
Thank you. Thank you for inviting me and for setting me up so well to talk about this. All right. Is it just gonna? It is. Okay, perfect. So I have spent most of my career thinking about low-value care and overdiagnosis more recently, but from a really big system policy perspective. So in our case, thinking about that as sort of a provincial government lens. So I am going to focus most of my comments through the lens of a publicly funded healthcare system, which hopefully is applicable to many of you in the audience too. And I have no particular conflicts to declare, so I'm going to take that off. And so just to reframe, you've heard a lot about why this has been a problem, and you heard from our three previous speakers really that patient focus and thinking about it more broadly. But when we're thinking about this from a publicly funded healthcare system, important to remember, as our speaker before lunch reminded us, that when we do have a fixed budget, or we're trying to operate within one, we do have scarce healthcare dollars, and when we're spending them on things that aren't providing us any benefit, there is less resource for other people and for other things that are beneficial to different patients or populations. And in our context, we talk a lot about how that takes away headroom or budget space, really, for innovation and high-value care. So here, our context, if you're asking to do something new in the system, one of the things you might hear is, we have already spent every dollar in our healthcare budget. Where would you propose that we find that funding from? And I think, thinking about Todd's context, it's all great for me to present him with, well, here's a budget argument, and he still says, that's great, I don't have $5 million. Where would we find that kind of money from? So that's sort of how it really translates in quite a colloquial way here in our system. So when we started this work several years ago, we thought, well, we'll start by going into the healthcare system and asking people, very high-level leaders in Alberta Health Services here, and then our parallel organizations across the country, as well as people within the government, what are some of the things that are stopping you from moving forward and taking action to address low-value care? And here's just a picture of what they told us, and I've got the references up in the top there. And they really identified 4 different tensions that we thought, naively perhaps, if we could help them address these different tensions, perhaps we could take some action and move forward. So the first was really having that thought about strategic thinking and immediate success, really recognizing that it's great to want to target low-value care. I still have an operational system that needs to take care of 4 million people on a daily basis here in the province. So whilst we would love to take the time to make changes to our healthcare and think really strategically about how we could be delivering care differently tomorrow, 5 years from now, 10 years from now, most of my human resources are focused on meeting the immediate needs of the 4 million people that I have to care for tomorrow. So that's a really big tension that they identified. There was also, as Jessica commented on, this tension between practice-based research and academic-based research, and that effectiveness is sometimes a big barrier where we are told that these are the clinical things we should be driving for, and that doesn't translate all that well to the individual patient-doctor perspective or interaction on a daily basis. We also heard that there are groups that are haves and have-nots. And so what I mean by that is that groups that are well-funded, can attract lots of research dollars, perhaps dollars from industry, can get those pillars around them to support change, and then other groups that don't have that kind of support around them and don't have any capacity to make any kinds of changes in their systems. And so resources was a real barrier for them. And then last, as Todd talked about, incentivizing versus maximizing value and money and the way that people are financially rewarded in our healthcare system is a big barrier to wanting to pursue change because, as Todd noted, sometimes the reality is that having a high throughput and just cranking through patients and dealing with the immediate need in front of you is a way to maximize value, and that's the way you're paid, and that's what incentivizes you at that financial level. So from that, we had three different kind of prongs of areas, different areas where we thought, well, we could start thinking about how we could create some supports for the system to move forward. So the first was really thinking about engagement across multiple different levels of the healthcare system, identifying and prioritizing where to take action, and then noting that they didn't have very much guidance or any methods about how to make change. Is there something we could do there from a research perspective to support them and guide their action? And I should just note that policy does tend to be very, very embedded in its context. And so we approached each of these with a process or an approach or a methodology that we hope would be transferable to different kinds of healthcare systems. And so you could adapt or adopt it into your own local context as it made sense for where you stood. So the first thing we went out and sought to do was to develop a process. So really responding to that have and have-nots kind of approach. We went out and asked our stakeholders, what would a process that you would be willing to stand behind look like? And we did this partly because it's so politicized. So the idea of pulling back care or targeting low-value care does require some support from the government to actually get to that point of action. And they're hesitant. It's a very risky proposition to stand behind a group that is trying to change care. And so we said, okay, what would be the attributes of a system that you would need that you would then stand behind? And these are the 5 things that they told us. So it had to be data-driven so that they could step back and say, hey, we're not preferentially attacking one group or another or prioritizing one group of patients over another. This is where the data tells us there is a problem, and that's what's guiding our actions and our change today. It had to be routine and replicable, noting that change management is very hard for all different aspects of the system. And if we were going to invest as many resources in making the change as we thought we might free up from the change, the system was not interested in that. So it had to be something that was sort of easier for them to do on a routine basis. It had to enable large stakeholder engagement, had to be actionable, so something they could actually do, and yield a high return on investment. Again, with that point of change management is often very resource intensive, and so it was only worth their effort to do something if it was relatively large in its scope in terms of impacting patient care in a meaningful way, and if a cost-driven mechanism was the desired outcome, that it would yield a big change in the way they were spending their resources. So we have tested that out in BC, and it went okay. We have some tweaks, we have some learnings to do, but definitely the process themselves, the government was very comfortable with us actioning on. One of the other things we heard a lot about was building the right team. And I'll just draw your attention to the patient box up at the top and echoing some of the previous speakers' comments around the importance of co-designing and bringing in patients from the beginning of these initiatives and all the way through to action. You'll also notice here industry representatives, which can be a really awkward one, but we learned very early that, there is a very heavy industry presence in some of these areas of care, and involving them from the beginning was a crucial part to being able to get close to action, because they are a very invested stakeholder, and they're very well organized in different parts of the healthcare system. And just to underscore the importance of that patient voice, this is some work that a student under Dr. Stelfox, who's one of our colleagues here, undertook. And what she'd looked at was a systematic review of strategies to tackle low care decision making. And the outcome that she looked at in these studies was the event of low value care being undertaken by the patient. And she looked at different studies that included patients in the design of the materials. So here at the top, you have patient-oriented education materials being the intervention. And in this bottom half is the shared decision-making, where the tools that were used were co-developed by patients. And what you see is that it's effective when patients are involved in the designing of these materials. And just to benchmark this for you, compare this dot here, of 0.58, to a Cochrane review that also looked at shared decision-making without specifying co-design by patients, and they found an effectiveness estimate of 0.76. So it is more effective when patients are involved in these initiatives in a meaningful way. So the next thing that we tried to tackle in our research agenda was to really look at how could we support people to take action. So what are the questions that you would need to ask yourself before you tried to move forward in this space? And so we came up with what we call a playbook for addressing low-value care. And really, we identified 5 questions based on sort of the who, what, why, and how kind of approach. And so the idea here is that you could work through each of these questions in your own context as a stakeholder team, and through this identify what are the different things that I have to think about before I try and design any intervention. And so this is what it looks like in a figure when you're thinking about some of the answers that you might have to those kinds of questions. So you would be asking, well, what is the value of the technology that we're trying to change the use of? What is the current utilization gap? What are the available tools and resources to me? And this is a crucial space to be thinking about how you can muster all of the assets that you might have around to implement change. What are the levers for change? And some of these are more or less effective than others, and we actually know quite a lot about that in the behavioral change space. And then what is the desired outcome that you're trying to target? And then from there, putting all of those pieces together to design your final implementation for optimal technology use. Throughout all of that, thinking about who the different actors are that will be affecting change in this space. And just to close out on some final reflections before we open up for questions, I think through all of this really learned that it is a very collaborative activity, and who is around the table and how they are authentically engaged is crucial, and that will depend on the different settings. For us here in Alberta, I think I've learned it is perhaps more important and more critical to have a very, very diverse stakeholder table to work with than it might be in different areas, but really being thoughtful and deliberate about who is being engaged early and throughout. The question of who is accountable is really a hard one to answer. No one is really accountable for low-value care at the end of the day. And that is a big problem, because the person who is accountable is the one that steps up and takes ownership for the outcome. And that's a very risky proposition for different places in the system. And so I think until we have that person pushing, or that part of the system that's pushing forward, it will remain very much in the background with a lot of momentum for a system that's operating the way that it is operating today. And then finally, I mean, we were in crisis before COVID, and now I think we are in even bigger crisis area, particularly, well, I shouldn't say particularly, but in Alberta, it feels like a different kind of crisis. And that is a great opportunity for change. So I don't want to be one of those person that looks and like, where's the silver lining of the pandemic? But I do think that crisis can be an incredibly powerful driver for change that would not have been possible in a different context. And so we do have a window, I think, to think quite differently about how we structure our system moving forward, and targeting low-value care in a systemic, structural way, which is what I think it will take to really line up all of these different pieces that you heard about from the different speakers before me. So thank you very much. All my stuff.
So glasses?
I think those are Todd's.
Todd. Fiona, thank you very much. I think that was a perfect way to end the session and possibly the whole conference. Okay, I'm going to take a few questions from the audience and then some online. Please keep your questions short, and I'll ask the panelists to answer succinctly as well.
Hi, Timothy Wilt from the United States. Thank you. So I'd like to know how you define low-value care, and then how you message it and the responses you get for your clinicians and your patients, because it requires benefits, harms, and costs. When costs can be tricky, they can move around, and some very expensive things can be very high value, and some very low cost things can be low value and have very big budget impacts. So how do you address that? How do you figure out what your return on investment is?
Yeah, so maybe I'll just jump in first and then invite the panelists. So you're speaking my language with thinking about costs and benefits. My training is in health economics. So certainly not to mix up value with cost, as you're articulating. I think in the low value space, it has been defined in the literature in two different ways. The first is that the harms to a patient or a population outweigh the benefits or the likelihood of benefit. So that's, I think, more intuitive for people. When you add in the cost perspective, thinking about is the investment of resources required, does that outweigh any possible benefit or the likelihood of benefit to a patient or a population? Much more controversial and harder to think about. But I will just say that we do that implicitly in healthcare all the time. We think about the things we're going to pay for out of our public funding versus not pay for. And so whilst it's an uncomfortable conversation, I would much rather that we think about it explicitly with data than implicitly as a system would do through rationing or wait times, or simply pushing it into the private market would be an option here in Canada. So great question. And then how
do
you
you message
communicate
it?
that, I took
get
the easy
buy-in.
part, I'm gonna pass it off now.
Todd?
Yeah, I can jump in while others start. So, I mean, it's a great question, right? And so as a clinician, you know, low quality care, low value care, is if somebody does the same test twice for the same end result, to me, that's pretty straightforward. As a cardiologist, we have lots of expensive drugs and other things. We tend to try and look at the health economics of it. What is the cost per quality adjusted life year and the ICERs, and some things are good and some things aren't. Those are simple and straightforward things. The rest of it is very difficult. How you relay that to clinicians, one is there is a fixed budget. This is what we can do. We have to make hard decisions based on what we have knowledge for. Other is a little bit more gray, and getting people to shift the needle in terms of that culture of it is you don't need to do that test for every single patient. You don't need to prescribe that medication. Prescribing is not a bad thing. Doing less testing, less is more, those sorts of things. But it is a difficult thing. People are set on the way that they like to do things, whether there's any financial implications for them or not. And the elephant in the room in our system is that a number of people are rewarded financially, but even if that's off the table, you put everyone on salary, et cetera, there still is an expectation from patients, there's an expectation from colleagues, and that's hard. And you know, you need to figure out what that looks like for different individuals, what the motivations are, and make it okay not to do those things. But yeah, patient buy-in is super important, right? I mean, a lot of that it is way harder for me with a patient in front of me to explain why I'm not going to do something as opposed to not. And because I'm on salary and I am a specialist, I can spend 20 minutes and say, I'm not going to do an echocardiogram for you, and here's the reasons. Are you okay with that? Whereas sometimes the path of least resistance is just to check that box, and people do it. So that shared decision-making is super important. That is at the heart of what I heard from this discussion today.
Yeah, and the message, like money and medicine, if you put it in one sentence, is still a dirty word. And so when you talk to your patients and family members and stuff, you have to really go into, first you have to get to know what they value, and then go in from this aspect. If you argue money and budget, you're probably right up against the wall. And so it's really, And that's what I meant with the courage to address the harms and really explain that. Again, that needs time, but it will bring the rewards then.
From the doctor, I mean, I do health technology assessment as well, but from the clinician point of view, I think for buy-in, the easiest thing is if you go to a group and you say, what do you guys think is low value? What do you want to fix? And you give them their information, and they can choose to do what they want with it. But it goes a lot better than the top down. So if it's bottom up, the challenge is silos. So, in my institution, we're like, we order way too many whatevers, echoes or INRs or who knows. And you could save like hundreds of thousands, millions of dollars by lessening that. And the clinicians are behind it. They're like, okay, if we do that, then can you give us funding for a new cath lab? Because we need it, because our patients are undertreated. And if you could, they did it in New Zealand, and it worked. The Divisions of Family Practice in New Zealand, Dee Mangan, who's not here this year, she could tell you more about it, but basically they set up a structure. They said, this was way back when, but just an example, our patients can't access their dialysis. They need rides to dialysis. Why don't we stop ordering unnecessary, say it was mammography, and give us half the budget back, not to us as physicians, but to our clinic, and then we'll use that money to pay for rides for our patients to go to dialysis. So if you can break down the silos and you can let the clinicians and the patients decide, this is something that matters in our community, like, we'll save you money, government people, but give some of it back to us to use for something we know that we need. I think that's a way to win, but I don't know how to break silos, if you can do that.
Okay, great. Tim, thanks for that question. We'll take, I promise we'll finish on time, but we'll take one more question from the back. Then I'm going to ask the panel, because we've started talking about solutions. You're allowed one solution. Okay? If there's one solution you're going to prioritise to make change happen, to change the dynamic, what would it be?
Sure. My question is just about many.
It's not the same question, is it?
It's not. Many of you talked about that we're not measuring the right things, and the things that we are measuring, they facilitate more overuse. And many of you mentioned that we need to start measuring more patient-centric KPIs. So what are some examples that you think we should be using in healthcare systems, but also in research when we're evaluating health technologies?
Okay, can you keep the answers short, please? Who'd like to go first? Fiona, you're nodding. I can only see you from the back. Your head's moving.
I've
You
got to
go.
stop moving. That's a great question. So I do think more regular measurement of quality of life would be really useful to think about, like, not only are we doing things to this patient, but is their quality of life or their ability to engage in usual activities improving? I think for us, it would also be great to start measuring the patient experience and the patient satisfaction. I think, Jessica picked up on this. I really enjoyed talking to you, the fact that you just listened to me and believed me. Those are valuable things that I actually think their therapeutic value is a little bit underrated. So those are just some things off the top of my head.
Tom.
Yeah, I was thinking exactly the same thing. We do cardiovascular trials to look at mortality and stroke and heart attack. Quality of life is being built into those. Something that adversely affects that is rehospitalizations, and so we're starting to see more of that added. So things that keep patients out of the hospital is bound to be linked to quality of life.
The research, some of it's being done, but you have to be careful. Patient satisfaction is correlated with increased mortality, which may not be a bad thing depending on the patient. But questions like, do you feel cared for? Can you walk to the bathroom? Very basic things, but I think we need to ask patients more what those metrics should be, and then form patient-reported outcome measures and patient-reported experience measures. Like, you go to TripAdvisor and you're looking for the hotel, and one review will say, fantastic hotel, super fun, crazy parties, amazing. And if you're a mom with little babies, you're like, oh my God, this is horrifying. I don't want to go to that hotel. So every patient looks at things differently, and there are researchers at UBC, Nick Bansbach, I think, is working on this, where maybe patients can give a report of their experience, and then when they're thinking about, do I want the knee surgery or not, they can see how it helped other people. One person said, the surgery made my knee pain worse. Another said it made it better. Oh boy, I don't want to be in that category. And so from hearing from others, they can make a decision based on real world outcomes.
Involving patients early on and really accept them as a partner and listen. Again, like I said, it needs time, but I think at the end it will help. If we really take the time early on, it's the same like with the the advanced care planning. If we do that early on, then we're not in tough decisions or in crisis mode later.
Okay, thank you. Right, so the final question. You're allowed one sentence, and that's it. You can't have a very long one sentence, sort of James Joyce sentence. So just one sentence on what's the solution. Name one solution that you'd like to prioritise.
Okay, the three things I said.
No, only one. No, you can't cheat. Just one.
A different one. I've been thinking and reflecting at this conference. I think I'm wondering why we are the way we are, the people at this conference. I don't know what it is, but one thing I would be curious to test would be early exposure to palliative care as a trainee, learning
Okay.
how to have those conversations.
Okay, Annie.
You took my thunder, and, because this is really something like the advanced care planning, make it mandatory and focus on quality of life, especially towards the end of life.
Fabulous, thank you. Who's next? Todd, you're ready.
I would embed the over-testing, over-diagnosis, over-treatment into the curriculum early on for our students, so they grow up with this as their culture.
Great. That's applause for all of you. Right, Fiona, final word.
I would go for something around accountability. I don't know exactly how I'd implement this, but there has to be someone in the system who their role is to, they are accountable for the system moving towards being high performing.
Fabulous. Thank you, the panelists. Great session. Thank you so much.